If we have such poor access in the US to see a specialist, the average wait time is 26 days. To see an endocrinologist is 70 days. To see a dermatologist is more than that. And AI really helps us scale and improve our efficiency from a systems perspective. It allows us to learn insights on managing side effects like we've never known before.
Welcome to Target Cancer Podcast. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as TheOncDoc on social and news media. And today we're going to talk about something that I've really been frustrated about in care when it comes to cancer care, but not just frustrated, really just concerned, because I was like, there's no solution. What are we going to do? And when I say that, what I'm really talking about is when we get into more kind of novel, therapies, and people, thank goodness, are able to live long, meaningful lives, in many cases with stage 4, not stage 4, whatever that case may be. We've learned and realized that with things like immune therapy and the high-dose steroids that you have to use for even non-cancer stuff, it gets very challenging when you have stuff with your endocrine axis. Endocrine axis just means like all of the pathways and stuff that go up and down, upstream, downstream, that we maybe, in my opinion, are a little haphazard with when we just give, hormones left and right, testosterone, whatever. There's a method to the madness. But what happens is with these treatments, that axis can get thrown off. And having the means in community America, which, by the way, is 85% of America, to be able to know what to do and why it's important when it comes to sugars getting out of control, or thyroid problems, or parathyroid problems, or pancreatitis, all these things that can get disrupted with immune therapy, you could see how that's an issue, right? Or not even known. Adrenal insufficiency. You're dehydrated. We're going to give you fluids. And you're like, bro, I'm not dehydrated. I'm drinking the same amount. I'm nothing's changed. And they keep saying that. Well, it could be because your cortisol is low. So how do we do this? And what do we do if you don't have a specialist around? Well, we have a specialist that is not just any specialist. They are an endo-oncologist. Dr. Afreen Shariff has graduated from Duke and has recognized how important endocrine is in oncology. The same way we had a cardio-oncologist, Dr. Susan Dent, when we were talking about all the cardiac and heart stuff that can go unnoticed. But she not only has hopefully some insights on how, to handle these spikes, what happens when the sugar's bad, and does it impair therapy, does it not? We can hopefully get into some of those things. But more importantly, how can we make this a thing that can help us get on top of it? Again, because that's a big concern, and sometimes you don't know what you don't know. So in this field of endo-oncology, now we're talking about the things that are related specific to cancer patients. I assume either for metabolic stuff that relates to what happens when you have a cancer disease process, and also the therapies. So with all of that said, Dr. Afreen, super excited to have you.
Well, it's my pleasure, certainly, Dr. Juneja, Sanjay, to be here. I'm absolutely thrilled and honored. And I think this is great to talk about something that is so important. When I talk about endocrinology and the overlap between cancer and cancer treatments, whether it's developing cancer or treatments itself, or long-term side effects that occur from cancer therapies, I think of endocrinology as kind of an amoeba. It goes into these nooks and crannies of cancer care, and it's a very nuanced space, even within the space of endocrinology. And that's why it's so important to recognize that you do need endocrinologists who understand the hormone-related side effects and also understand the newer developments that are happening in the cancer space, and can put those two together, kind of merge the science and medicine and the art of medicine together, and actually apply it to a patient who is really going through a lot. And there's a lot of moving wheels, especially when we're talking about cancer patients. It's a very different spectrum of things that we're dealing with, right? It's not a patient with type 2 diabetes that walks into my clinic. This is a patient who is going through a new diagnosis of cancer. They probably had a whiff of diabetes before, something we call pre-diabetes, and now they're getting steroids. The new diagnosis of cancer is making them anxious. The new treatments with steroids are making them anxious as well. And plus their blood sugars are really high. And now you're telling them, wow, your sugar is 400. You need to see a new specialist who can manage this. It is a lot for patients. And I think it is important to keep this discussion with patients really relatable to them, that we understand what's going on with them. We understand how to treat them and reassure them that this is something that can be managed. We're here to support oncologists. We're never here to take away from the cancer treatments or ask your oncologist to stop your treatments or choose something different, right? And I think that's kind of the space that we work in, is the supportive care, where we want patients to get the best benefit, from their cancer treatments while taking away the stress and the anxiety and the complexity associated with managing these toxicities. So endocrinopathies or endocrine side effects are perhaps one of the most common things that patients will encounter throughout, even before, during, and after their cancer journey. So really important to work with oncologists and endocrinologists, all in that same space.
Yeah. I mean, just to give an idea to anyone listening, just steroids, when you hear that, you might be like, oh, they're great, they're not great, they, whatever. But the pathway is, midbrain stuff, anterior pituitary. It's saying, I need some more cortisol at this moment. And it's sending a signal down to your adrenals. So suddenly it's relevant if, lung cancers go to adrenals and so do other things. Do you have your adrenals? Are you able to respond to the signal that tells your cortisol to go up? You might say, well, why do I need cortisol? To keep your blood pressure up, to make sure you have the stamina to walk the stairs, to function at work. So we're talking about even the qualitative, quality of life measures that may be impaired. Did you know that if you have steroids for 2 to 3 weeks that are, continuous, that process goes to sleep, and all of a sudden your brain is like, yo, I'm good. I'm getting it from elsewhere. Well, did you know that when you have fever or COVID, and I see this all the time, or any kind of infection, and somebody's been suppressed, quote unquote, because of steroids, meaning things are asleep, you're not able to send the signal to get your heart rate up and then get your pressure up and get through this illness. And that happens when I sometimes see autoimmune patients for, non-cancer stuff. And I'm like, yo, you need stress dose steroids because your body would do it naturally, but it was put to bed because you're on something from the outside. I mean, that one thing is something that, I just see over and over again. I'm like, this is why you feel bad, because you maybe had to be on the steroids for XYZ or whatever else. And then another example I'm going to say really quickly is, and correct me if I'm wrong, but somewhere around 200 on your sugars, they're like, I just keep hearing, doc, I don't get it. I'm just so tired. I'm so fatigued and I'm drinking water like crazy. And I say, well, that's because once it's over 200, your kidneys will lose the tug of war against the sugar as it comes out. It wants to keep your fluid in you. It wants to keep you hydrated. But the problem is it will always lose it. I will always lose to a sumo wrestler and tug of war. Hurts my pride, but it's true. And what happens is that's why I'm like, if nothing else, can we get it underneath so that we can keep you hydrated? Because by the way, your chemotherapy hurts your kidneys. And if it's labile or kind of goes up and down just from hyperglycemia, osmotic, diuresis is what they call it. When your kid spills sugar on the floor, my wife's like, no, we have to mop it. And I'm like, why? Because it's sticky, because it pulls water. This is just two of the things that I mentioned, right? And so it's just so important and gets challenging when you're having these things, kind of integrated and temporary. Like the steroids may be a shot before your chemo, but then that 24 hours or 12 hours, if you're sitting at 300, it's not saying, oh, you're suddenly insulin resistant. It's just the fact that you got 12 of Decadron. But we need to account for that because you're also getting cisplatin, which can hurt your kidneys, and therefore, some kind of management to bring it down for 24 hours. I don't mean to say this for anyone listening to freak out because of like, I don't have an endocrinologist. We don't have someone in town. I didn't know that because we have a solution for you. And that's why Afreen is on this podcast, because when I found out about this, I was like, this is what people need everywhere immediately. But with all that said, it's complicated.
It is. And I couldn't agree more, and this is a lot. And what we've seen is that this is, as you mentioned, the 12-8-8 of DEX, right? This is such a common thing. Patients come in, a lot of folks actually don't even know that they get steroids, right? Because they're getting it part of their chemotherapy. And they're getting it through their IV. So when you ask them, you're like, did you get any steroids with your treatment? They're like, I don't think so. What are steroids? They think of steroids as bodybuilding testosterone, right? They're not thinking of it as dexamethasone or prednisone. And they're thinking of it from that term. So they're saying, no, I actually don't. And then when you look at their chart, you're like, oh, wow, you have received, and then this is what you're getting. So we actually tend to treat them very differently because these folks are getting what we call intermittent steroids. You're getting 12-8-8. And you don't get it day 1, day 2, day 3, and nothing after that. And you get it again after 2 weeks or 3 weeks, depending on the cycle of your chemotherapy, right? So they feel amazingly great when they get the 12 and 8, almost like they're flying off the walls. They want to fix everything in the house. And then they're also eating around the clock. Their sugars are up. They're peeing all the time. So it's kind of what we describe as nervous energy, right? They have lots of energy. They have lots of things they want to do, but they get tired when they want to do it. And they get very anxious because they can't complete projects, or they want to do so much and they can't achieve it, right? So it's a very different feeling that patients go through. So we kind of describe it. A lot of my patients describe it as this nervous energy where they have a lot of ideas, but they can't execute on it. And that frustrates them again. And plus they're peeing all the time. They have disturbed sleep. When you're getting dexamethasone, they can't sleep. They call themselves, I feel wired, right? I can't sleep. all night. And when it wears off, which is typically about the 48 to 72 hour time point, they feel like their car went from 200 miles an hour to 40 miles an hour, which is where they're supposed to be driving. But that deceleration makes them feel terrible, right? So it's not just the fact that being on steroids has these effects, it's also when they get off of steroids, every few weeks, they feel that sudden deceleration from 200 miles an hour. It's almost like someone slammed the brakes at them, and then now they have to slow down suddenly. And it's a very distinct feeling that patients go through. And the more we ask them about it, the more they describe this a little bit more in detail. When you talk about fatigue, in my clinic, it's like white noise, right? Everyone comes in with fatigue. So I tell them half my job is to kind of figure out how much of it is coming from a hormone deficiency or excess, and how much of it is not coming from that. So half my job is to tell you what it is, and half my job is to tell you what it's not, right? Because fatigue comes in so many different shapes and sizes. Having cancer itself makes you feel tired. Your chemotherapies, your immunotherapies can make you feel tired, right? And then being on DEX intermittently, that can make you feel tired. They're losing weight. They're losing muscle mass. They have a lot going on at home. So, expecting someone to feel good and not tired during that time is really unrealistic almost, right? So they are going to have some degree of fatigue. What we parse out in an endocrinology clinic or an endo-onc clinic is the time-wise, the degree. We're talking percentages like, how bad do you feel today that you didn't feel 3 weeks ago? Because you don't have a baseline for these folks, right? They're like, they will tell you that I felt great before I got diagnosed with cancer. I've never felt normal, right? According to them, the way they feel, they just never felt the same since they got started treatment. So why is it that this time it's important? Because they're come to see someone to get help, right? So we're talking to them in percentages and degrees. How bad, what is being affected right now? Are you struggling to go to the bathroom, for example? Are you canceling invitations? Are you not going grocery shopping because of the fatigue? So that is a different degree of fatigue that patients go through. And then we have a biochemical analysis. So I always say, walk like a duck, you can walk like a duck, but if the labs say you're not a duck, you're not a duck, right? So the good thing about endocrinology is that we have labs. We have numbers that we go through, and the body reads them like a barcode. So if you got the numbers and they're right, that means your symptoms are probably not coming from the lack of a hormone or the excess of hormone, right? And then we start going through our checklist of things. Okay, you got fatigue. Are you sleeping okay? Are you over-caffeinated? Do you have sleep apnea? Do you have D deficiency? Do you have anemia? Right? What else is going on? Are you going through, an adjustment disorder? Is this affecting you? Is there a lot going on in your household because of your new diagnosis? So we kind of go through that checklist once our labs come back normal. So that's why I say half our job is to tell them what it is, and half our job is to tell them what it is not. If we know what it is, we're always there to treat it. And that's kind of the conversation I have with most of my cancer patients when I see them.
We pardon this interruption real quick. If you're enjoying this podcast or find it valuable for what we discuss and the education and how people see and think about cancer in general, we would very much appreciate a like, subscribe, and especially a share so we can bring that information as maximally and broadly as possible. Thank you so much for listening. Basically, you're telling me, and I'm sure it'll take the whole podcast, so we're going to tell them where you can get this kind of endo-oncology support either locally or wherever. You're telling me there are things additional that's just steroids wearing off and chemo, symptoms starting to occur is oftentimes what we say. Because when I think about it, intermittent steroids, most lymphomas, a lot of blood cancers, right? Myeloma, you're taking once a week. Prostate cancer, you're taking it with your pill. I mean, there's so many where you need steroids, ITP, you need it prolonged. So there's other factors, and it sounds like things that you can actually help with a crash or whatnot that can actually help reduce what seems like it'll be never ending, right? Prostate cancer therapy is when we need the steroids orally with an oral med. It's a long time. Pre-med, when we say that, before your treatment, we mean pre-meds, that can be a long time, especially with breast and, when you're getting into weekly stuff. So the point being it's that there are things to be done and account for predictably, or things that are only after exhaustive, assessment to say this is purely just the side effect of treatment or whatever. So that's huge. I mean, I want to ask you, what are the things you do for all this? But we'll pin that. I'm going to write it down for a period of time. So, steroid crash. So, with immune therapy, the tricky thing is I need everyone to know this, because even though I tell my patients this, sometimes it takes reminding them. They're like, oh, but I've been getting it. And I'm like, yes, these things can occur, and on average occur months after, right? It's not an allergic response. Like if you have something that doesn't sit well, you'll kind of know, and you're like, oh, I had it once, it was bad, or my second time. This is something that's like gravy, as they say. It's just going on, getting the immune therapy. It's basically just dissolving the stop signs, that cancer cells can express to tell your immune system, hey, nothing to see here, keep moving. And then over time, you can have these stop signs that dissolve away in places that the stop signs need to be there. So it could be thyroid, it could be parathyroid where the calcium starts getting high. It could be, and it takes being aware, which is what's, extremely challenging. It could be a mild pancreatitis. It could be a mild glucagon problem, which is the opposite of insulin. It could be, anything you can imagine in the access when it comes to autoimmune, including type 1 diabetes, is on the differential. One, I hope and I'm confident that AI will help pick up on these things a lot sooner before maybe a busy clinic does, right? Like you see it enough times, like, well, maybe they have no more insulin production. And all of a sudden, so there's all kinds of things that will assist picking it up on it sooner. But I'm sure, an endo-oncologist has a nice rubric or workflow of what labs are abnormal, what the symptoms are being reported, and a good idea of these rather elusive things. Because I was told, and with all due respect, I know the healthcare industry is deficient in a lot of things, but immune therapy, I think in some areas is having to be given by, OB-GYNs and urologists, because of, it's being used in everything. But because of my strong internal medicine background, I think I pick up on a lot of these axis shifts and things to, that clue me in. That's something that y'all, I'm sure, assess with, look at longitudinally and recognize that anything can be a reason if someone is on, one of these agents, which I think it's in dozens of tumor types at this point, maybe with some exaggeration.
Yeah, no, I think you hit it on the nail. And this is really a paradigm shift, right? When it comes to the way oncology, has been working over the last, say, century or so, right? We saw it in 2011 when we had the first FDA approval of ipilimumab for metastatic melanoma and non-resectable. So we started off with the hardest problem to solve. And then we've seen about 20 plus FDA approvals in many different tumor types and different settings. And we're moving from the ones that were really difficult to treat and people are dying of this. And now we've moved to early stage cancers and we've moved to not just pure immunotherapy. We moved into combination chemo and immunotherapy, like we're seeing in the breast patient population, right? So it's really opened up a new can of worms when it comes to side effects and toxicities, right? If you look at immunotherapy treated patients, back in 2011 when it started off, but 1.6% patients would qualify for immune checkpoint. Now it's 55%, right? It's gone up tremendously. So this is the holy grail of cancer treatment, right? We've been waiting for this in the oncology space. How do you use your immune system to kill something that is evading the immune system and forming cancer cells, right? It's almost like it's going through the radar and it's not getting detected, and now it's going into cancer. So how do you use your body's own immune system? So this is, when I started doing this in 2015, 2014 timeframe, I think that really drew me towards, endocrinology and the science with, the overlap with cancers and treatments and endocrinology was actually the science, because it made sense. You're taking your body's immune system and asking it to drive at 100 miles an hour. You're taking the foot off the brake, pushing the gas pedal, and now you're riding at 100 miles in a 40-mile zone. And it's supposed to do that to kill cancer cells. But in the process, you have some things that are sitting on the road just waiting to get hit. And those are accidents, right? And endocrinopathies or endocrine toxicities are common accidents that occur along the way. Because thyroid problems or thyroid autoimmune disease is the most common autoimmune condition, even in the general population. So it makes sense why an endocrinologist now becomes really essential beyond the traditional chemotherapies and radiation, which already, there's a lot of side effects and toxicities with associated with traditional treatments. Now you add this thing that is waiting to hit the endocrine system. And as you mentioned, there's so many things, like you have pituitary, you have adrenal, you have the thyroid, you have type 1 diabetes. I have clinics full of patients that have these problems. In a day, I will go through my half a session in the morning will just be adrenal insufficiency from checkpoint inhibitors or long-term steroids, And it's amazing how the practice has changed. I used to see patients with melanoma back in 2015. Now I see, I call it the new kid on the block, right? So every time there's a new FDA approval, I start seeing more of those patients coming in. Right now, it's the breast onc population, right? Melanoma folks have gotten better with managing toxicity, so they only send me the real big bad ones, right? They're managing the grade 3s very easily on their own. Whereas the breast oncs are still kind of getting used to it. So they're sending me more patients that way. So I know when a drug gets FDA approved, even before I see it in the news, I know that the population is moving. So it's just been a shift. And now oncologists need to be supported by these group of specialists, endocrinologists, cardiologists, rheumatologists, neurologists who specialize in that kind of translational space between the two. And I always say this, that never before in medicine have we all worked together so much. And I love doing this, right? I don't think in my practice, I've been 22 years in this field, right? So I've seen different things grow and differently, but it is such an amazing way in which, and I think it's the benefit for patients, right? Because when there's many heads involved, I think in this point, there are not too many cooks. It's like we have our different stations that we all work in. This is the endocrine station. This is the neurology station. This is the oncology station. And we go, it's almost like an assembly line. And the oncologist is kind of the gatekeeper in telling who needs to go where. And we individually have our own pieces of the puzzle that we're trying to solve. And all of those pieces solved together ensure that the patient's getting the right care and high quality of care. So I think this is a better time in the history of medicine or in the history of cancer in general, that all of these folks are working together, or at least thinking of working together.
1,000%. I mean, it is, for better, for worse, it's better for patient care, no doubt. Problem is the areas where you don't have it. And that's where I think burnout and overexhaustion is, or things being missed, which is the worst case scenario, is because of just, the availability of really the close examination that this stuff takes, which is why I was, very interested. You recognize this. You're at Duke, correct? That's where you're practicing currently. And you were like, well, what about all the people getting immune therapy everywhere else in the country, right? And there are places that even immune therapy is still not being used in tumor types that have been approved for years. Again, not out of, I hope, and I want to believe not out of negligence, but just out of being overextended, let alone an endocrinologist is familiar because it's not, being used, or it's being used later as these things are becoming more received or made aware of. And then if the endocrinologist even has time, there is endo-oncologist. So Citrus Oncology is something that you've tried to help democratize and get that access virtually, because we have something we can look at, labs. We have the stuff that, the symptoms, the notes, and hopefully it'll help people get that kind of care, which I just think it's been a fear of mine. Like I had white hairs and everything, thinking like, it's just so easy to miss it, even if you're aware of it. And then you can go downstream of everything from there. Now, I want to ask one question that you may or may not love or hate getting asked about, but it has to relate to what people think of as a classic when they say hormone, right? When they say, like, in the classic sense, I think, or I want to say non-medical sense, it's estrogen or testosterone. A part of my heart breaks primarily because of, especially with these patients, unfortunately, all of us are younger with cancer and need, basically complete blocking of estrogen, circulated estrogen in their 30s and 40s. And also men, where I'm blocking the testosterone. If you could just give us a little spiel, is it as binary as it feels? I know there's topical estrogens for intercourse plus minus, possibly some that goes into the blood. I know there have been studies on that may help some of those side effects with this menopause-like feeling that's kind of indefinite, or 5 years if you're using it after a curative surgery. And then also with men, when it comes to testosterone, I just would love, it hurts me every time, in addition to cancer diagnosis, in addition to potentially having done the curative thing, what comes after that? And it's challenging.
It is. And I think this was my clinic last week. In fact, I had a few patients with prostate cancer who, what I call, is going through menopause. So, they're having the same symptoms of quality of life is the question that I ask at some point, right? So when they're on active therapy, obviously this is an on-target requirement that their estrogen be shut down, their testosterone be shut down. And when they come to see us during active therapy, obviously there's nothing else we can offer other than support, because I wouldn't put a person who's having an ER-positive breast cancer, put them on estrogen so that they feel better. Or someone with prostate cancer, I wouldn't put them on testosterone so that they could feel better. So in those times when they're going through active therapy, it's unfortunate. Yes, they are going to go through symptoms. I think the first thing, most important thing, is acknowledging that the symptoms that patients are going through are real, and the feeling that they're having is truly because of a medication. I think a lot of times having that closure is very important for patients to process those symptoms, right? So when you have a conversation, you flip the conversation around a little bit and say, hey, you know what? I understand you're going through this. I understand that these are the symptoms that you're experiencing. And then I kind of sort of expect this because your estrogen is down in the dumps. And this is a requirement. We don't want your cancer to come back. And this is an absolute requirement. So how can I help you in other ways? Are you not sleeping very well? Are you having hot flashes, right? So can we treat them in SNRIs? Can we give them other medications that can help simmer down the symptoms that they're going through? Can we do some cognitive behavioral therapy for these patients? So to send them to a psychologist where they're talking about mindful approach towards symptom management and understanding this better and adopting to that. Because as you mentioned, this is the new norm for them. And unfortunately, this is a requirement from the perspective of treating the cancer, right? So when the question comes to, do you want to be 6 feet above the ground or do you want to feel better? A lot of patients are going to be like, I want to stay 6 feet above the ground. I will take these symptoms, but I don't believe that a remission in a wheelchair is a remission, right? I believe that a remission is truly when patients are thriving. I don't like the word survivorship. I absolutely don't. I don't use that for my patients. I call them thrivers, especially in the survivorship phase. Because I'm talking to them, I want you to thrive. I don't want you to hang by the thread. Almost survivorship means that you're just hanging in there, right? You're just like hanging by this thread that is just going to drop any point, right? You don't want to be that. You want to be a thriver. And you're going to, and I call them warriors or I call them thrivers. That's how I identify and talk to my patients. And you want them to live the best version of their life. So what else can we do to improve your quality of life, right? Now, when they're post-active therapy, that's when the question comes is, what is the stage of the tumor? What is the chance of recurrence? So that is a conversation I would have with the oncology team. Like, how worried are you about this patient? And it's more common so with prostate cancer patients treated, they've had their surgery, they've had their radiation, their PSA is undetectable for years, and their testosterone is low because they've received testosterone suppressing therapy for multiple years. And I will get the go-ahead and the blessing from the oncologist to say that I'm monitoring this patient, and I will be monitoring their PSA, for example, in addition to them monitoring it. When I put them on testosterone therapy, we go through risk and benefits with patients and tell them that, yes, there is a chance that this may feed the cancer. It's not going to cause prostate cancer, it can feed it. And then when it does happen, we'll be the ones detecting it because we're going to monitor you very closely, right? The chances of this coming back, there's always a risk-benefit discussion that we have. And I don't really truly treat the prostate cancer patients to a testosterone level that is therapeutic for a general population. Like their testosterone levels are in the 50s, 60s, 70s, sometimes 10, 15, and normal is like 400, 500. And the treatment range is 400 to 700. I don't need to get to 400 to 700. I could get them a better quality of life by just going up to closer to 200 even. So I just say the numbers are here to make sure that I'm not overdoing it, right? But you're here to tell me if it's working for you. And that's where I draw the line with treatment. You don't have to hit the top target doses where you're feeding the prostate cancer cells. You're really treating the patient for quality of life. And I think that's a kind of discussion that's important. And with a very well-informed patient, most cancer warriors they're absolutely informed. And it's something about cancer itself, the treatments and the fact that you have to be on top of your A game when it comes to being on your appointments. They're just very well-informed, very engaged. And it's so much easier to have that conversation with them and explain this to them. And they're willing to take a informed decision on what would benefit them. And I think with the right support, that we're going to monitor them, we're going to watch you. If something happens, we got your back. That kind of discussion really comforts them in taking some difficult, challenging decisions. So I would say it's really patient-specific. Depends on the type of tumor, the stage, the chance of recurrence, whether someone should go on these replacement therapies. But I think the focus should always be quality of life and pushing them towards thrivership and survivorship.
Yeah. I mean, you made a very interesting point that I'm just going to highlight again, that when you have testosterone cancer and say it's curative, right? And you had a full prostatectomy. I just need to make this, even though it's a little tangential. But if you had your entire prostate removed, or when it comes to breast cancer, now purely breast, doesn't mean ovarian or anything else, bracket, just breast. And you have a true, bilateral where the breast tissue is essentially almost all gone. That is a different scenario when it comes to the risk of quote unquote, a recurrence, in the sense that if you're giving a hormone that, like you said, it's only going to do something if something is not in the thing you removed, right? So if you took the prostate out and there's cells elsewhere that are prostate cells because they spread and it could be years before you know, it will declare itself, but it's already out because this is in the scenario where 100% of the prostate was taken out. Same with breast. The challenge with breast is most people, the guidelines don't recommend it, rightfully so. I go with real world evidence, but not everyone has a bilateral complete mastectomy, right? And so there, it's not the same thing that applies because you can actually potentially, as far as we know now, invite, a similar process of a cancer if you still have remaining breast tissue. Because we know, and we've had, Jason Fung and Siegfried and several guests talk about how it's the environment of an area that sometimes is one or two switches away from another cancer. So that is a very important point, is that there's one risk when it comes to having a second thing come up if you have that organ. And then there's another thing to say if in a stage 4 setting that you may be talking about, or if not stage 4, to have the organs completely removed, if that makes sense. I just think it's a very valid point. I will also say the thing that really hurts me sometimes, and I hate being the one to deliver the news, is I've seen more and more men when they come in for whatever reason, high blood level, for example, right? So they're not anemic, they're the opposite. And I find out they're on testosterone. And I ask, well, why were you on testosterone put on, et cetera, is when people get their levels checked, not only at the right time, because there is a right time, but even under other physiologic duress, i.e. sleep apnea. Like there was 2 patients we had in the last couple months. I was like, bro, I've told you this, like please get that sleep apnea test because you're tired. And, that CO2, that's the surrogate for bicarb, is like constantly high. Their malapati, which is how much of, you can see behind them, like you're just very high risk. I think it'll change your life. That, and I assume, correct me if I'm wrong, elevated cortisol levels due to not getting nice, REM sleep that gets you to restore to sleep. That elevated cortisol level, that physiology brings down your testosterone. And now you're getting treated for something. And remember at the beginning, I mentioned when you're on something long enough, you shut down. Your body's like, why would I do any work that I don't need to do? Call it one of the sins of the Bible. If we're cellular the same way that we are as humans, it just stops. And now they're troubled because they do have sleep apnea, and they're like, but I want to get off of this. And apparently it's overshooting because almost every endocrine process in our body is dynamic. It's dynamic, second to second, minute to minute, situation to situation, a scary email. Everything shifts our stuff dynamically, literally every second, minute to minute. People need to be replaced. Don't get me wrong. But the replacement is never quite as dynamic. No, it's never as dynamic as the body. And that's what, that's why I was so excited about pumps. And now I do policy steps, try to get pumps, especially in younger populations, because yes, it's good to get long acting and short acting, but what you really want is just whatever you need acting at the moment, right? And that goes for everything. So that's another big point too, is I don't think I've had a patient that went and got put on testosterone during, say, curative treatment, because again, the fatigue, the physiologic stress, which could be downstream of emotional stress, I expect testosterone to be low. But it goes into educating all of these things up front and having the time and capacity to get into deep histories that I can empathize. In this case, in communities, sometimes isn't possible because people are waiting to see weeks, with the active cancer just to see an oncologist. That's where, the desire for hopefully more to be able to explain that, because it's not their fault. Like they're told by another physician, testosterone's low. That's a fact. And you can replace it, it'll feel better. That's a fact. But are the circumstances that cause the testosterone to be low temporary or not? And that's where deep assessments need to happen, which is, again, why I've been, just very humbled that you, I guess, firsthand, even more than me, saw this and was like, let's get people those assessments, because all they want to do is feel better. That's what breaks my heart all the time. I'm like, they're just justified. And you said, tell them it's not your fault or expected. Basically, you were saying validation. They just need validation of why they feel the way they do, and accuracy of the reason for the validation. Is it just, is it sleep apnea? Is it whatever else? Everyone deserves that. And I think that validation is not binary, but it's far more partitionable, if that's a word. And that's what an endo-oncologist in these circumstances does. What is justifiable and validated, but what is not, and what's left on the table? Because otherwise, every reason to go seek it out themselves, because they're not getting the answers. Like, I get that, right? Like, we get that. So that's just what's really cool with, Citrus and everything. But I'm sure you've seen tragic stories similarly where people are stuck on things now, but I'm sure you're undoing them too once you're able to get to the root cause.
I think patients they just want to feel good.
Exactly.
Like they're
right too.
The reason they're taking time out of their life, getting an appointment, taking time off from work, or driving 4 hours to see somebody is just because they want to feel good. And I think we need to explain to them that we're on their team. We really want to help them. But sometimes the answers are not in the endocrine system, right? I always tell them, if there's something in the endocrine system that can treat, I'm absolutely going to treat that. There's no doubt about it, right? I'm not going to sit and watch you, go through this if there's a problem in the endocrine system. If I find something, and I'm going to hunt for that. And if I find it, we're going to fix it, right? But I can't fix something I don't treat. But it doesn't mean you're not feeling good, or you should be feeling good, because there's nothing wrong with the endocrine system. So I think you could absolutely be feeling bad despite the fact that your labs are perfectly fine, and your endocrinologist is saying nothing's wrong with you, just because the cause is not
endocrine.
It's something else, right? And part of our job is to kind of go through that. And, this is kind of what we do. And I'm sure other specialists do this as well, cardiologists. We're looking at it from a singular problem perspective, right? So it's a very different discussion, because when you go to your oncologist, they're really trying, and they are trying to help you out and do what's best. But they have an elephant in the room that they have to tackle, which is the cancer itself, and the treatments, and the direct kind of impact of that. And when you have these other small things in the background, number one, there's just not enough time to talk through this, even though while they have the best intentions, they either don't have the time in the clinic to talk to you about all of this, or that they're just not, they haven't done this in a while, right? It's like me putting in chemotherapy orders. Sure, I've done it many, many years ago. Could I do it today? Sure, I could do it. Would I prefer an oncologist do it for your safety? Absolutely, right? So that's kind of where we all are. We're all trained to do things, but it doesn't mean we do this every single day of our life, right? And we're really good at it. So I think what patients need to understand, which is a shift even just not for oncologists, but also for patients, is that earlier, the oncologist used to be the person managing everything, right? Because it was a different set of problems. It was like hair loss. I'm feeling tired. I'm having diarrhea, nausea, weight loss. I'm feeling just weak. My muscles are, withering away, how do I increase my appetite? I'm hurting here. Those are the typical traditional problems, right? Now we've added an elephant in the room, which is all these different immunotherapy-related toxicities, which require a very sophisticated approach. And it's way beyond the scope of what oncologists are comfortable doing or trained to do or want to do, right? Because they have a lot of other things dealing with it. And trust me, you don't want your oncologist to be managing your type 1 diabetes and your rheumatoid arthritis. You really want to go to a specialist who does this day in and day out, and they could wake up in the middle of the night and rattle out the answers that you need. That's the kind of person you want to go to. And I think this is the reason why I decided to start Citrus in the first place, because there was such a need, like you mentioned. I know all the side effect specialists in the country, a lot of them around the world, by their first names, right? And that's a problem, because there's not a lot of us, right? And we have 5,600 patients plus every single day that are being diagnosed with cancer. And about 40 to 50% of them are going to have some side effect or the other in some shape or form, right? And about a third of these are going to require specialists because of the use of immunotherapy drugs, in addition to your traditional chemotherapies and other things. And are oncologists comfortable managing? Do they have the time to manage it? Are they the best people to manage the side effect? So this is a shift for patients as well, that you really need someone who does this for a living, is an expert in this space to really manage it. So Citrus really provides that, as you mentioned, democratizing it, taking the academic approach outside of the ivory institutions that we all live in, and taking that to community cancer practices, taking that to patients, putting it in their hands, where they can go to a website, citrusoncology.com, and choose the state, the specialist that they want to see, and they can book a consult. And right now, we're actually offering free consultations for patients in the state of Florida. And we really want to keep it very nimble for patients, because I understand financial toxicity. I lived in this space with cancer patients, held their hand for more than a decade, and I don't want to overburden them with any cost. So that's the mission with which Citrus was developed. One, we want to make it virtual. Two, we want to provide patients with multi-specialty teams outside of their oncology teams that can support their cancer doctor. You keep your cancer doctor, but if your cancer doctor needs help, needs an endocrinologist, needs a cardiologist, needs a nephrologist,
you have all that,
and a dermatologist, you need that help. You just go to Citrus Oncology. Your oncologist can go to Citrus Oncology and book an MD to MD consult. So Sanjay, if you have a patient who has blood sugar 500, you just go to citrusoncology.com and you put in a referral. It comes as an e-fax to us. We reach out to your office and get all the data for the patient in the sense we are all HIPAA compliant, so it's all protected information, protected platforms. We get the patient's medical information that is pertinent to the problem that you're asking help for. And we review the case within 48 hours and basically tell you what I would want you to do, or someone like me would want you to do, right? I would say get the patient on insulin. The patient's on 12-8-8 of dexamethasone. And now I want you to do different doses of insulin for different days, right? Because it makes sense. Your sugars are going to be different based on the doses of steroids. So you need a very nuanced approach to this. So we give you that recommendation. You start implementing it with the patient, and then you refer the patient to us. And we basically take the patient's care on. Like you would refer to any endocrinologist, you would refer the patient to Citrus Oncology. We bill insurance, right? So we are not putting any burden on the patient, any burden on you from a cost perspective, right? It is just like you're sending a referral to any endocrinologist.
Oh my gosh.
Is that this is virtual. It's convenient for patients. We get them in quick, and you get experts in the field of side effect management. You're not just seeing a random endocrinologist. You're not seeing a random nephrologist because they have the next opening. You're seeing a side effect specialist, because Citrus was developed by experts in the field. So we have a team of national and regional experts that design guidelines around side effect management. Actually, Susan Dent is also one of our advisors, and you mentioned Susan Dent earlier in the podcast. So we have these thought leaders in the field who designed the platform to deliver targeted, evidence-based care just for side effects. So any endocrinologist who works through our platform gets educated on how to manage side effects and also implements care like I would. So it's almost like you're making it scalable. You're making my mind scalable across the Citrus platform, which is implemented by local endocrinologists, because they now understand how to deal with because they're highly trained endocrinologists.
Right.
They're board certified, amazing at what they do.
Yeah.
Just don't know the nuances, and we teach them those nuances.
Because the problem is I need that Venn diagram where they all meet. Like, nephrology is complicated. All of these things are complicated. And surely, in most communities, if I have to guess, 95% is just all the regular renal stuff or kidney stuff and all the regular rheumatology stuff that has nothing to do with immune therapy or cancer, relevant nuances physiologically or temporally or relationally. Most things are static in the sense that there's a disease process and you're not actually like inciting something, at intervals, right? Like if diabetes, yes, your diet matters, but we're talking huge changes. When I had residents shadowing me, like, I think one of the most common, not shadowing, but rotating, one of the most common things is I had no idea how much internal medicine was in oncology, because I look at the breath rate, respiratory rate, and the CO2, and then the electrolytes to see if there's even a tubular problem within the kidney, right? I have to know if it's proximal, if it's not, the potassium's low or something's changed with the sodium. Now I got to ask my entire staff to see what blood pressure medications that were changed, because does that explain it? Or is this an IO related problem that's on the renal function or on the proximal tubule or ATN, acute tubular necrosis? But also I'm having to do now, when it comes to respiratory rate, diaphragmatic stuff to rule out disease or irritation, I'm checking lipases and amylases and C-peptides and all of it. I mean, like vitamin D, PTH, the timing, the T3, the T4, because you can't just willy-nilly just send somebody. And then what really hurts, is sometimes when you get a reflex. Again, I don't think it's like lack of, responsibility, but just seeing what you see, like you said, the note says unlikely to be, immune therapy because patient's been on for 6 months. And it was just one and done. And we waited 8 to 12 weeks. And I was like, you don't understand. Like, that's when it happens, but how am I going to get a hold of them? It's just ejecting. And it's like, I'm getting 24-hour urines as an oncologist that sees every tumor type and as a blood specialist.
Yeah.
But I know my wife and I are both hematologists and oncologists, so we can take the time. And here at our center, fortunately, our patients don't have to wait long lengths, and we're still able to see them and do these kind of in-depth things. But specialists are hard to get. I mean, neurology, a guy was mentioning he was going to the eye doctor to just get, and my vision updated, and it was like, respectfully, sir, it's a little late in your life to just all of a sudden, that your vision, it was so mild. You just was saying something casually about having to run out of there for an optometrist. That was like, I was like, no, I know it's been 6 months. It could be immune therapy. He said, no way, I have a good response. Turned out to have some crazy palsy from immune therapy. and he absolutely had to get the next few cycles because he was riddled with cancer all over, injected through his eyeball to basically that was the only way we could continue because it was sent to appropriate ophthalmologists that did brain MRI imaging, whatever. And now, bless, 3-4 years later, alive and well, no disease. If we didn't do that, the whole thing, either blind or prematurely terminated. So my point being is same thing, dry mouth. Oh, it could be the chemo. It could. But if I have the time, I'm going to ask about Sjogren's and then dry eye irritation. Hey, I notice you have eye drops now, and then you're getting constipated because lubrication all shuts down, which could be immune therapy. We have to ask about every single thing. I'm obsessed with your rash. I'm obsessed with your irritation.
Yep.
I hope anyone listening to this could understand how challenging that is. If anyone is seeing an oncologist and getting their treatments, I had no idea all these axes were complicated, and they are because whether you believe it's God, evolution, whatever. It's a intricate orchestration on the allergy immunology side, endocrinology side, GI side. Let me not even get into gut microbiome and neuro health and psychiatric health that has to do with the gut microbiome. It's a mess. It's crazy. And you need specialists that do it and see it every day to make considerations that they were making yesterday, not to a fault of anybody else. I get annoyed when I go to the car place and they're like, yeah, you need to get someone to check your so-and-so because that's how, but we fix this. I'm like, well, why couldn't you fix it? And they're like, well, that's not what I do. And I respect that. That's what you do. But to me, you're both car people, right? Or the AC person, you need this person for this. I'm not a master plumber. I'm not going to get frustrated. I'm like, I guess it's just more complicated than I realize, even though to me, they're both in the pipes. They're complicated. And the body's the same way. And you can't just take a general and do that. So I'm very relieved to hear basically what you're telling me is the same way I would bill for a specialist and send the records to somebody in town. I could also do that virtually with someone that may and likely has a higher volume of these more idiosyncratic, not for me because it's my world, but in general population as someone else. And I think that's just so necessary. And I believe AI is going to help a lot of that, not replace anyone, but help you all see higher volumes and me know better when a referral is appropriate or not. They're just earlier tip-offs because of things at depths of understanding and pattern recognition that will take a while if it's a new drug. You need experience to recognize and find a pattern to then know to refer something. And you need the time to ascertain all that from the patient. So I hope anyone listening could be like, yo, that's a lot. Yeah, you need pattern recognition first. You can't have patterns with a new drug unless you see it enough, miss it enough, found it enough. Then you send a referral. And so I think there's a lot that could be dusted off of potentially what just seems like a very tough process when it comes to anti-cancer therapy and treatment.
I think I absolutely love what you said, Sanjay, about, being able to predict. And I've worked in predictive modeling, especially for toxicities and patients who get admitted. How do we be more proactive and reactive and take EHR data and basically build ML models to predict with reasonable accuracy which patient is likely to go into the hospital after they've been initiated on immunotherapy drugs? And is this because of a toxicity? So I worked in that space of predictive modeling. And I think the questions the answers we really need is for the patient sitting in front of us, right? It has to be a digital or a patient phenotype that we're able to sit down and tell exactly the patient in front of us that this is your risk, not the risk from a study that was done in 50,000 patients in 5 different countries, right? So that's kind of where I really see the vision of this. And Citrus, the way it's designed is we have a front-end service model and back-end data model, because I work with claims data, I work with EHR data, and there's so much garbage that goes into the EHR system. There's so much information, but it's not usable. And that's the problem that we are having today. We have a lot of information. We need to clean it up to solve a particular problem, right? And until we think of it in that way, it's going to take a long time. I really think that, yes, AI, I am a big proponent of AI. I build AI tools. So I know that I've been doing it since the early 2000s. So I built this and I know that this is a space that needs improvement. But unless we put usable, clean data in, and you can then query the data and build models off of it, that's the only system that's going to work, right? So Citrus is designed. So my co-founder, he's and my partner in life and crime and everything that you can say, he's a computer science PhD from Carnegie Mellon. So machine learning, he's been doing machine learning even before it was a thing, right? So we both kind of combined our dinner table conversations and be like, we're going to do a service front end and a data back end. So that's why when I say that we have a very academic approach to this, the platform that is designed is curated to collect clean, structured, problem-specific data. So if I want to query the database for high blood sugars, secondary to steroids, right? I can plug and play and get out not only the recommendations, the data points, everything, and expert opinions, which is the most important value, right? For scalability, efficiency, because we're not looking at just the US market, right? We're looking at a global market because side effects are not something that's specific to the United States. Cancer is not something that is just specific to the United States, right? So treatments are being given. Patients are suffering. If we have such poor access in the US to see a specialist, the average wait time is 26 days. To see an endocrinologist is 70 days. To see a dermatologist is more than that. This is general dermatologists and general endocrinologists, not people who know about cancer drugs, right? Remember that. So this is the wait time here. Imagine what people have in other countries, right? And AI really helps us scale and improve our efficiency from a systems perspective. It allows us to learn insights on managing side effects like we've never known before. So this was the idea, to take that kind of very academic, very rigorous, evidence-based, expert-driven approach and applying that to community cancer practices and community patients where 85+% patients are actually receiving cancer. They're not getting it at the ivory centers of the country. There are fewer patients who live close and can afford that kind of treatment. Majority of them are getting it in smaller places where access to endos, access to cardiologists, access to rheumatologists is really poor. Forget about the ones that know cancer drugs, just regular docs. It's very hard to get in. So we've taken a very different approach to solving just one singular problem, which is side effects. And I think if we can do that right, I think we're going to be saving a lot of patients. We're going to be helping a lot of patients. We're going to improve the quality of life for patients and help our oncologists do what they do best, which is taking care of cancer, right? They're trained to do that. They love doing that. And we're piling on way too much on their shoulders and taking away from the joy of them practicing cancer care. And I think we really want to defocus. It's kind of like, do you want to do destructive innovation or do you want to do sustained innovation? I think we're stuck in the space of sustained innovation. We're in this whirlpool. We have these processes. Let's try to innovate within that. And I think oncology care needs disruptive innovation. That's what we want to go. We want to go from 0 to 1, and we want to really disrupt that space where we can, it's very mission driven. It's focused on patients. It's focused on quality of care. It's focused on access and data and insights on improving care for those patients. So that's basically in a nutshell what we're trying to achieve over here through Citrus Oncology.
No, I love that. I mean, when you were explaining that disruptive versus sustained, I think of what's always, a big pearl of advice is don't continue something necessarily. This means sometimes for relationships, work, professionally, of course, believe yourself, this, that, and the other. But sometimes if something is dysfunctional, when you start thinking about what I put in and where we're at, you're like, well, how else can I make the next thing work? And that's the innovation you're talking about. When you take a step back, you look at this system that's like got, a piece of rubber here, a screwdriver here to balance the weight, and you're still going, but it's problematic. And it's like investments in stocks. I mean, there's so many examples. Sometimes you're just like, just because I have, and this is where I'm at, doesn't mean it's the best course of action. Like you just have to, do something if it's headed in the wrong direction. And that's what you define as disruptive, which I love. We talked a lot about the front facing, like how it helps people, but the data piece is huge because what people don't realize all the time is the guidelines and stuff, like you said, are studies based on X number of thousands, lucky if you're in other countries. It doesn't necessarily mean like your guidelines that you're getting are based on where these studies were done. So the geographic area, diet, of course, matters. We don't even know the beginning of how much it can influence metabolism and other drugs and this, that, and the other, microbiome, but even just genetics. Let's just talk about, the kind of population that's in the area, blah, 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 blah. If you want stuff that's more, personalized to you, that's stuff that's like in the background at much larger volumes, achievable and processable. And that's what you're trying to do. You want to help understand, are there little dialing up and down needs for people based on a certain location and geographic or genetics, whatever it is. The only way we get that is knowing what the data is, meaning what's happening to people when we're going on the previous sustained innovation guidelines. And is there something else and a different approach? What I got really excited about with wearables is, to your point, I might have recommendations, let's see what happens, but a deeper analysis is, okay, we may not know exactly what Sanjay, whose mom is from Assam, which is really East India, and dad's from New Delhi. I don't think there's many Assamese, half Punjabi people in my circumstance, especially my mom's half Bengali on top of that. But what does matter is I'm still a human. And so my physiologic difference on how my breathing has changed during certain phases of my sleep, how much I'm actually having to pant or my heart rate goes up from my baseline compared to usual in the last 2, 3, 4, 5 days. These are things now that go even a bigger depth. I can't say a bigger depth, but bypass all the idiosyncrasies we know to a degree. We just know that a 10% change in X means a concern for Y, right? So that now all of a sudden you're realizing it's the change from baseline until we figure everything out that God or the universe, whatever you believe, has orchestrated in its complexity. At least we know what the deviation is to be able to prompt us to X, Y, or Z investigation. And that's achievable today with watches, steps, respiration rate, pulse ox, potentially. You talk about a perspiration to figure out when you're sweating and to why, what circumstances, ambient climate. Now we can at least say, then in most of these circumstances, there was an occult, viral infection or whatever. So that's a whole nother depth of not just AI, because to your point, it's only as good as what you train it with, but then also being able to do the personalized precision thing, which you're trying to enable with Citrus. So with all that said, Afreen, I think I'm going to sleep better tonight than I have in a long time. I don't think I've said that in a long time because I'm usually more stressed going to bed after these talks because we talk about how complicated things are. But at least this immediate concern of mine seems like there are people like you and your partner that are making things at least solvable, that aren't so crushing and anxiety, So this has been really good. I'm telling you, this is the first time I think I'm going to bed encouraged because I know that this is the thing. So
thank you, Sanjay. I think this is fantastic. Absolutely. I always love hearing your podcast, and now I've enjoyed talking to you and sharing about what Citrus Oncology can offer. And we're active in Florida right now. We're accepting patients, so where patients are welcome to just go to the website and log in and make their profile and request a consultation. It's welcome. We welcome all cancer patients, and we would love to give them expert opinion and even do direct care for them through insurance coverage. So their cost is zero, right? We're offering free consults right now. So we really want to drive the point that, number one, patients need help. And I think it's important that these concerns that they're coming with and knocking on their oncologist's door are right concerns. They just need to get plugged into the right doctor to manage those side effects. It's just kind of matching the right doctor, the right patient to the right doctor to the right place, right? Just kind of doing that 1 + 1 + 2 is equal to better quality of life for patients. So I think, I love to hear that you're going to sleep well. That means tomorrow morning you're not going to be fatigued, which is awesome. I love to hear.
There you go. That was the invitation.
But I appreciate the invitation to come on the podcast. And I hope that some patients are listening and oncologists are listening and they could utilize services that we're able to offer through Citrus and actually benefit their patients. Because I really see a win-win for everyone through this. I think everyone wins in this situation. And I would hate to see patients just sit around and wait for someone to weigh in and their cancer treatments are held and their cancer is progressing. That is the most hurtful thing that I see in clinic, is that someone waited 3 months to see me and now their treatment's been held. And I'm like, why would somebody do that?
Or inappropriately terminated.
Case, and I would give you an answer in 48 hours, right? Yeah.
Or terminated because they thought it was a side effect of that and turned out not to be. I mean, there's so many, it's scary to think about, So, well, we appreciate that so much. I'm so excited. And you said everyone wins, but also humankind, because I'm discovering you're also trying to analyze the whys and how come me's and how come this other stories, that's all happening in the background in a depth of study that's going to be hopefully transformational. This is so exciting.
Well, thank you, Sanjay, for having me on the podcast. It's a delight talking to you.